Good evening, everybody. Welcome to the first Open Hand Therapy Initiative webinar of 2026, which is brought to you in collaboration with the University of the Witwatersrand in South Africa and the South African Society of Hand Therapists. Today we have a special ethics edition. Usually we only have a 1 hour webinar, and tonight we have 2 hours where we'll be considering hand injury care for all, understanding the need and being part of the solution. And we have 4 speakers who will address this topic, and we'll have a time of questions and discussion after each. Our first speaker will be Dr. Kiran Agarwal-Harding, who will look at the global unmet need for hand injury care. So taking us for sketching a global big picture of the need and how we might approach addressing and responding to this. Then Terri-Ann Abrahams, an occupational therapist, will be looking at developing a therapy service in an underserved context. Nicola Ehlers will then look at advocating for best practice and improving patient outcomes in under-resourced settings. And then Erica will have a look at staying whole in a broken system. So taking care of oneself as a clinician, working in challenging contexts. But welcome to this first webinar. If you are unfamiliar with the Open Hand Therapy Initiative, please feel free to have a look at our website or contact us with any questions that you have. But without further introductions, I would like to introduce our first speaker. Kiran is joining us from Boston, Massachusetts, where he works as an orthopedic trauma surgeon and an assistant professor at Harvard Medical School. Kiran is a global health specialist and social entrepreneur, and he's dedicated to improving trauma and orthopedic surgical care delivery in resource-limited settings. He's the founder and director of Harvard Global Orthopedic Collaborative, which is dedicated to improving access to essential orthopedic care for underserved communities. And this collaborative has ongoing academic partnerships in Malawi, Ethiopia, Gambia, Haiti, Kenya, Rwanda, and Sri Lanka. He's also the founder and director of SONA Global, which is a nonprofit dedicated to improving essential trauma care through affordable device innovation and surgeon education. Kiran has numerous publications and numerous awards, and it's a real honor. We thank you for your time and really look forward to what you're going to share with us this evening. Kiran, over to you.
Kirsty, thank you so much for the kind introduction. It's really sweet of you. And I do really appreciate being part of this webinar. I think it's phenomenal, the work that you guys are doing. Let me just share my slides and we can go ahead and get started. So as Kirsty said, I'm Kiran Agarwal-Harding. So I practice as an orthopedic trauma surgeon, but I'm trained as a hand surgeon. So the primary clinical practice of mine is primarily upper limb trauma and reconstruction. And I spend a significant amount of my time working in limited resource settings. I have primarily been working in Malawi, so you'll hear a lot about Malawi in today's presentation. And so Kirsty was kind enough to invite me to talk about understanding the need for hand injury care and being part of the solution. And so, of course, what I'll talk about today will just be a very small part of that. And certainly a lot of it is just my perspective. And so I welcome plenty of discussion. And of course, there are many other ways of addressing this tremendous need. But I hope I can convince you all today that there is a need that is worthy of being addressed and we can meaningfully make an impact. So just one quick disclosure is that I am the president and founder of SONA Global, as Kirsty just mentioned. It's a nonprofit organization. We develop affordable medical devices and multilingual education to improve access to essential trauma and orthopedic care, and including hand care, hand surgery care. So today I'll be talking about what is the global need for hand injury care and how should we respond. So let's start first by talking about injury and the global burden of trauma. So when I first started exploring the space of global hand surgery, global surgery in general, this statistic really stuck out. This was, 15 years ago. And unfortunately, this statistic has not changed. Trauma kills more people worldwide than tuberculosis, malaria, and HIV/AIDS combined. And that's just fatal injuries, not just fatal injuries. That's fatal injuries. Non-fatal injuries cause an even higher burden around the world. And unfortunately, the incidence of injuries is rising globally. And that rise is primarily in low and middle income settings. When we talk about trauma, for every one trauma-related death, there are 10 to 30 people who suffer non-fatal injuries. 75% of these are musculoskeletal injuries, of which hand injuries are included. The rising burden of musculoskeletal trauma is, as many of us know, from road traffic injuries, natural disasters like earthquakes, like this image from Haiti, or violent conflicts, of which there are many going on around the world, but also from falls, from just living on this planet. We fall and we injure ourselves, and still the majority of injuries are related to that. Unfortunately, 90% of people in sub-Saharan Africa and South Asia, where most countries are low or lower middle income, have inadequate access to safe and affordable surgery, compared to 4% in countries where I practice like in the United States. So to address this, there are many, many facets to approaching the problem. But this is sort of the cycle that we have taken at our organization, and I think it's worthy of discussion, certainly. So the first step is, of course, collaboration. Bringing us all together, as this webinar is a perfect example of, to discuss the challenges and develop appropriate solutions, that's key. Collaboration is key. The next thing is investigation. Without evidence and scientific rigor, we can't hope to make a meaningful difference for our patients around the world unless we truly know whether the difference has been a positive one. The next step is prioritization. There's so much to tackle around the world. We must prioritize. That must be driven by evidence and driven by the priorities of our colleagues who practice in limited resource settings. And then the fourth step is implementation. Once we develop solutions to tackle the challenges, we have to actually make sure that they get implemented effectively. And that implementation can come in the form of many different ways, but one kind of concept that I've carried with me from Paul Farmer, who was a famous global health specialist at Harvard, is the 4 S's: space, staff, stuff, and systems. It's just a nice way of thinking about how to build capacity in limited resource settings, or in any setting, really. So as I mentioned, I work quite a bit. I have worked quite a bit in Malawi. Malawi is for those who don't know, in southeastern Africa. It's a low-income country, population of about 20 million people. And just as an example, I'll tell you a little bit about Malawi to give you a sense of the challenges to hand injury care that are present in settings like that. 83% of Malawians live in rural areas, as you can see from this image, and more than 50% live below the national poverty line. And that number has actually increased since I created this slide, actually. Malawi, when I first started going there, had the 4th highest road traffic mortality rate. Now it's the 9th highest. That's not because they've solved a challenge and they've improved the mortality, like reduced the mortality rate. That's because other countries have caught up. If anything, the mortality rate from road traffic injuries has gone up in Malawi, and that's due to increasing commercialization and urbanization that's occurring all around the world, including in low-income countries. So 1/3 of Malawians are living with an untreated surgical condition, very high proportion of the population if you go into the communities and survey them. And 30% of these untreated surgical conditions in Malawi are of the extremities, of which hand injuries are certainly a part. And the burden of musculoskeletal trauma in Malawi is rising. And to give you a sense of the kind of injuries, these are all cases from when I have visited Malawi that I have had the privilege of helping manage. Certainly, there's a lot of upper limb pathology, high energy trauma, mangling, extremity injuries, violent injuries as well. The image on the right of your screen is a panga knife attack. There's also the burden of neglected trauma. There is such a high volume of trauma and such a limited access to surgical and rehabilitation care that inevitably there's a huge epidemic of neglected trauma. So neglected Galeazzi fracture, neglected humerus fracture leading to a non-union. This is a young boy who developed, on the right-hand side, who developed a compartment syndrome that was neglected and presented with this ischemic limb. Infections, tremendous burden of infections, neglected trauma in children and adults, and of course the complications of surgery. You know, inevitably we will have complications from surgery, but sometimes when the training and the resource limitations are are present, that can even increase the burden of these complications and further complicate the entire picture of trauma care in a setting like Malawi. So to give some context, in the United States, by the numbers, there's one orthopedic surgeon for every 11,000 Americans. I'll say we're saturated in Boston. There's even more orthopedic surgeons per American citizen in the US. But this is the situation in Malawi. There's one orthopedic surgeon for every 1.3 million Malawians. And I'm sorry to focus on orthopedic surgeons, it's my bias, but certainly I think these ratios will give you a sense of it's very similar when we think about specialists who focus on hand surgery or therapists who can provide hand rehabilitation. So this is the consequence of this kind of inequity, a huge burden of injury and limited access to care. We have musculoskeletal health inequity, patients waiting for surgery, patients waiting for rehabilitation, limited access to essential care. So how can we address this? This is the approach that we have taken, and certainly it's not unique to our organization. I think many organizations could probably map their work to a very similar kind of paradigm. And that's building on a strong foundation of bilateral partnerships, forming relationships, at least from our perspective on an academic level, with colleagues who work in high income, middle income, and low income settings, all together tackling this challenge and sharing their perspectives with one another. And then on this firm foundation, we build several columns that hold up this, roof of this ideal of musculoskeletal health equity, which is perhaps not attainable in our lifetime, or maybe even in our children's lifetime, but certainly a lofty goal that we work towards. So the columns that we've sort of divided this into is research, that's our evidence generation, education, that's building local capacity, advocacy, changing systems, changing funding mechanisms, and then resources, equipping surgeons and therapists with the tools they need to actually provide the care that patients need. So because most of my work is focused on sub-Saharan Africa, I'll share the findings of a paper that I think is very relevant to today's conversation. But I do hope that for those of you who are not familiar with sub-Saharan Africa or don't work in sub-Saharan Africa, perhaps from Latin America or from Asia, many of the themes here I think will resonate with you. So this is a paper that we did on the need for hand and upper extremity surgery in sub-Saharan Africa. We did a survey of almost 200 respondents in 39 countries representing Central, Eastern, Southern, and Western Africa, low income, lower middle income, and upper middle income countries. Most of the people who responded to the surgery were orthopedic surgeons. We also got some plastic surgeons and general surgeons. Most were working in government hospitals. 88% of the respondents reported that it was mainly generalist surgeons who were primarily managing upper extremity pathology. So not a lot of access to specialized hand surgical care, not a lot of access to plastic surgical care, although in some countries they did report that plastic surgeons are picking up the slack for hand injury care. But generally speaking, it's general surgeons or general orthopedic surgeons, general plastic surgeons without hand specialty training who are managing these injuries. And when you ask, are they available? Many people are saying that neither hand nor ortho are available. Hand specialists are really available only in limited settings and only in the high income settings, generally speaking. When we ask about the kinds of injuries that folks are managing, this sort of give you a sense. Soft tissue injuries, including burns, and pediatric and adult elbow fractures were mentioned primarily in the lower income settings, and they become more and more common as you get to lower income settings. But you can see here that, of course, there's a full litany of cases, but certainly it's these ones in particular that I'll focus on because these are the ones that are most burdening our colleagues who are working in low income settings: complex elbow fractures of kids and adults, and burns. So in low-income countries, more than 60% of the respondents in our survey were reporting seeing more than one case per week of adult forearm fractures or wrist fractures, pediatric forearm and wrist fractures, soft tissue injuries, including tendon lacerations, and then these pediatric elbow fracture dislocations. So pediatric forearm fractures were most commonly reported in the low-income countries in Eastern Africa, and the pediatric elbow fracture dislocations most commonly reported in the Southern and Eastern low-income countries. Again, this is in comparison to the upper middle-income countries. And just to give you a sense about, since we're talking about low-income countries in South and Eastern Africa, let's talk again about Malawi and the burden of elbow fractures. Or just generally pediatric upper extremity injuries. So of a population of 20 million, 44% are under the age of 15. And in fact, the majority of the population is under the age of 18. 1/3 of trauma patients are children. Supracondylar humerus fractures, which I hope some of you will be familiar with, are common injuries around the world. They happen when kids fall off monkey bars or fall out of a mango tree or just fall while playing in the playground. Most of these injuries are treated non-operatively in Malawi because of limited surgical capacity, despite the fact that for displaced fractures, the standard of care is, as I'm indicating in these x-rays, closed or open reduction and pinning. So we wanted to know what are the outcomes, right, of this sort of deviation from evidence-based care that's a result of limited capacity in Malawi. This is the standard of care in Malawi. A child is placed into straight arm traction on the wards. The arm is hung above their head until the swelling is decreased, and then they're blindly manipulated and then placed into a splint to hopefully maintain a reduction. If you look at the level of displacement, as the level of displacement increases, as you would expect when we look at these patients almost 4 years after they were treated non-operatively, the frequency of a clinical complication or functional limitation is exceedingly high. 80% of these children are reporting some kind of functional limitation in those type 3, like the most displaced fractures. And again, the level of displacement of the fracture, even controlling for delayed presentation, medical comorbidities, severity of the injury associated with fall or road traffic collision, they're still associated with a higher risk of cosmetic and functional deficits that affect their function. So the conclusion really from this study that we performed in Malawi is that these injuries are resulting in elbow stiffness, deformity, function, decreased function, and pain, and non-operative treatment is not really appropriate for these children. And there's an urgent need to improve access to surgery. And I would say there's also an urgent need to increase access to therapy for all patients. So let me also talk about adult elbow injuries. These are most common in these low-income countries compared to the upper-income countries. And what we're seeing more and more is that in the low-income countries, compared to the upper-income countries, elbow fractures are primarily young people having high energy trauma compared to elderly folks who fall and break their elbow, low energy trauma. It's really young people, working age people, providers for the family who are getting these kinds of high energy complex injuries that are very difficult to treat. The standard care in my practice certainly is dual plating of these complex intra-articular fractures, and there's obviously like a lot of literature and knowledge surrounding the kind of management of these injuries. But non-operative treatment remains a major player for patients coming from low-income settings. This is how a lot of patients are still treated, is with skeletal traction or non-operative treatment. In many patients, this is a case from India during the COVID pandemic, where care was scaled down in a country, India, where otherwise care is often available. Many patients are being treated non-operatively, and the outcomes can be reasonable, but are certainly not what we would expect for a young working person who needs to provide for their family. The surgical technology available to manage these injuries is fairly limited. These locking plates that can get very, very far close to the joint to put these screws to hold up the articular surface. So it requires some creativity. And this is a technique developed by one of my mentors when I was in my training, George Dyer, his Dyer wire technique. It's a technique of using these skinny wires against the joint surface to bring the level of fixation as close to the articular surface as possible. It's something that I use routinely in my practice in Boston, but it's also a very powerful tool in a place like Malawi, where we don't have these anatomically contoured plates, and we need to be creative about using affordable, accessible technologies like K-wires that are available almost everywhere to fix these complex fractures. So I just share that as an example of how we need to adjust sometimes to provide better care for patients in these resource-limited settings. I'll also mention soft tissue injuries, including burns. So these are most common, again, in the low-income countries in Africa, primarily in Central and Southern Africa. And then mangling injuries, compartment syndrome, more than 4 times as likely in Central African low-income countries, seeing more than 1 patient per week with these severe injuries which are highly complex, devastating, high chance of disability, and need a full litany of not only surgical but rehabilitative care to get a patient back to living a functional life. I think it's worthwhile discussing just briefly that prevention of injuries is really important. Most of the pathology that I've just discussed is traumatic in nature, burns and injuries and fractures. Low-income countries shoulder the heaviest burden, and fractures in children are very, very common in Eastern and Southern Africa, burns in Central and Southern Africa. And the Central African low-income countries report disproportionately higher burden of this trauma. If we look in Malawi again, we see that majority of patients who are seen with injuries are actually children, and most of them have upper limb injuries. So I just want to point out here that prevention really needs to think about children and how we protect children against these devastating injuries in particular, but also working age people. Again, falls is a big issue, as I mentioned, but of course, road traffic injuries and even assaults are another big problem, even in the pediatric cohort. So prevention of injuries, we need to think about fall prevention, young kids climbing mango trees during mango season, road traffic injury prevention, so preventing overcrowding of vehicles like motorcycles and these buses, and then burn prevention, preventing children from being so close to cooking fires and open fires and things like that. So let's talk a little bit also about chronic pathology, because we've talked a lot about hand injuries and upper limb pathology from the acute setting, but there's a lot of neglected trauma, and we see that in the upper middle income countries, it's primarily degenerative conditions that are presenting to the hospital and to the clinics. But as income group decreases, it's post-traumatic, neglected, and infectious pathology that dominates. So chronic elbow dislocations is a perfect example, and one that I really think is a major problem in low-income countries. Most common in Eastern African low-income countries and Southern African low-income countries. And these are very challenging to not only address surgically, but to rehabilitate, to allow a patient to have a functional limb. Burn contractures are also a big problem. Again, this is neglected burn injuries that are not managed acutely, and then present with these severe burn contractures, oftentimes from rural patients who cannot make it to the hospital in time. So compared to the high-income countries, these are most common in the Central and Southern African low-income countries, where more than 40% of respondents were seeing at least one case per week, which is a tremendous burden. And these injuries require very advanced skills to manage and to rehabilitate. And then in Central and Southern low-income countries, we're seeing a lot of chronic infection and Volkmann's ischemic contracture. These are complex injuries related to poverty in many cases and neglect and limited access to care. So when we asked our respondents to sort of answer simple questions about do you think that patients receive timely diagnosis, timely treatment, and timely rehabilitation, the vast majority of providers were saying no. And the barriers to care that people brought up, inadequate materials and implants, patients facing challenges paying for care, and then patients are lost to follow-up or have no access to rehabilitation. And so this is why I'm so grateful to be presenting to all of you, because I think you guys here, all the therapists on the line, are a major part of the solution that hopefully we can someday be for patients in these limited resource settings. So when we ask the respondents in this survey, do you refer patients with hand injuries and pathology to someone else? 50% are saying yes. And why? Because many of them are feeling uncomfortable managing hand pathology. So when we talk about prevention of complications, prevention of these, prevention of poor outcome for patients with these injuries, it has to be about strengthening the training of surgeons and therapists in these low resource settings. And especially in low-income countries, focusing on the management of these complex malunions, non-unions, osteomyelitis, chronic elbow, and complex acute elbow injuries and burn contractures. And these are oftentimes not part of the training for example, what I went through in my hand fellowship. But these are the essential skills that are needed in these lower income countries where a lot of this pathology can be very different from what we see in high income countries. So that's, again, where partnership is key. And so that brings me to the second half of this presentation. I hope I'm doing okay with time, where I'll just talk briefly about how can we build hand injury care capacity. And pardon my bias again from the surgical perspective. I think that all this does apply certainly to the therapy side. So we talked about building towards musculoskeletal health equity using research, education, advocacy, and resources. Bilateral partnerships are our foundation. Without these collaborations between colleagues across the world, none of the work that we do would be possible. And it's really about knowledge exchange, seeing practice in these different settings, understanding the challenges so that we can tackle them together. And we all have so much to learn from one another, no matter what setting we practice in or what our training background may be. So I've talked a little bit about research, which I hope I've made the point that it really deepens our understanding. It also plays an important role of building academic partnerships. By doing research together, we tackle the problems together because we build those strong bonds of understanding and collegiality. Once we do research, though, we need to actually tackle the challenges that we've studied. And so research must inform the education that we deliver to build hand injury care capacity around the world. These are photographs taken from a course that we ran in Malawi that was directly informed by the research that we had done in Malawi that helped us design the curriculum for the providers there. Now, we live in a global world, and we discovered this during COVID, that the tools at our fingertips, like Zoom, like all of us here today on Zoom, allow us to reach a truly global audience. And that requires us to be open to opportunities for increasing access through multilingual virtual content. So that's something that we've really embraced at our organization, is we have fantastic surgeons from Harvard and from around the world who want to lecture about certain key fundamental principles of care, but also their experience working on complex management and working in low resource settings. And that is converted into online content that then can be translated into multiple languages and reach a truly global audience. And we've really tried to do this through the form of virtual education conferences. We've run many now. I think we're up to 17 conferences, and we have a whole bunch of conferences coming up this year as well, mainly targeted towards surgical trainees and surgeons. But certainly, Kirsty, we should talk about doing something that's more focused towards hand therapists, because I would be thrilled to do something on therapy as well, or integrating therapists into our work. We've, over time, developed a kind of flipped classroom model that I believe really works well for the adult learner. And here I am yapping away and lecturing, and what we found is that lectures like this, oftentimes people zone out. And I'm sure many of you have, but that's fine. What we found is that the flipped classroom model allows, first of all, we record lectures and translate them into multiple languages, allowing for a curriculum to be much more accessible and digestible at someone's own pace. So they can go and watch the lectures in their own language at their own pace, digest the material, and then be ready for a live case-based discussion. We as clinicians, I think, learn best from cases. And that's really been the focus of our work, is these case-based discussions. And this is an upper limb case managed by my partner, Dr. Pierre-Marie Woolley. He's a Haitian trauma surgeon who's come with me to Malawi and works extensively also in Peru, and is a stalwart, continues to manage his department in Haiti despite the gang violence there. And this is a case of a gunshot wound that a woman sustained to the humerus, and he did this remarkably complex bone transport to fill the defect in her humerus and gave her a functional limb back. Unbelievably tough cases, incredible talent and creativity from our colleagues working in these low resource settings. And our goal really is to provide a platform so that Pierre-Marie can teach me and us at Harvard, but also other surgeons in Haiti and surgeons around the world who I think could really benefit from the skills and knowledge that he has to manage the kinds of injuries that they see. Over time, our network has grown. All of you guys can check out sonaglobalacademy.org if you're interested. It's all free. And a lot of content from our partners is totally free for folks from low and middle income countries as well. And we've now reached quite a number of people. And I'll also mention that alongside the conferences, kind of organically, what grew, I think, to fill a very natural need was an active community of discussion. So when we first started these conferences, we just created a very simple WhatsApp group to share flyers and information about these conferences. And very quickly, it grew with surgeons who were, first of all, enthusiastic about teaching, and second of all, had a need for sharing advice and receiving advice to help manage complex cases. So we have a whole community of many different groups here. I've just listed a few of them that I think would be relevant to this community on this Zoom webinar. And most recently, thanks to Kirsty, we created this global occupational and physiotherapy group, and it's slowly been growing as well. So I'm very, very happy for that. Um, you can't train a surgeon or a therapist just through webinars. Despite the value of this webinar here, I think Kirsty and the whole team will agree with me on that one. There's nothing like, you know, being hands-on and taking care of patients together and learning together in that clinical context. And so surgical coaching and mentorship is a big part of the work that I do. I bring colleagues from around the world with me to low resource settings, and we try also to bring colleagues from our partner institutions around the world to Boston so that there can be that true knowledge exchange and clinical skills exchange. And this is my perfect kind of setup. So here I am in Malawi, a beautiful new facility that was built with support from the Norwegians. And Chawezi is the primary surgeon. He is the Malawian trainee who is doing the case. He is the one operating on this forearm. And Shravya, on the left-hand side, she's now a fully qualified trauma surgeon, but at the time she was a chief resident on my service. She came with me to Malawi and she is assisting and I am supervising. And this is a perfect setup for, first of all, providing excellent care, but also providing the skill-based learning that Chawezi will take on to his practice. And now he's fully qualified as a surgeon and started his practice. So we're very proud to have played a small part in being there as he develops skills, which are just truly remarkable. So the moving on to the next pillar, I'll talk briefly about advocacy. Advocacy, I think, is really important, and part of the research work that we do is elevating voices, amplifying voices from our education and our research. And Dr. Linda Chikoto, trained as a hand surgeon, has done a remarkable amount of education research work in Malawi and has presented all over the world. And we've been really proud to again play a small part in the research projects that she's done and be by her side as she's presented in all these international forums to share the situation in Malawi and also share meaningful solutions. As we do research, we bring in smart people and we start thinking about ways that we can address the needs that we identify. And so this is a project that we did looking at access to essential diagnostics, including X-ray, and developing sort of policy solutions to that, like targeting specific hospitals in order to expand capacity to cover a majority of the population, that sort of thing. We take these and we pitch them to policymakers and we work with the local government and put on, attend and support these large conferences that sort of hopefully push the needle towards better access to care for the poor. But policy takes a long time. Policy takes a long time. There are patients in need now. And so a big part of what we do is also about mobilizing essential resources. There are donations from partners around the world who we will help put into the hands of surgeons who desperately need them. And as you can see from the right-hand side, Michaela is one of the nurses who works with me at Harvard. She's there in Mzuzu, the northern region of Malawi, and she's teaching how to use this new donation that has been provided there for managing fracture care. But a donation is just a stopgap in many ways. We need to think of creative solutions. And so I'll just very briefly talk about the work that we do at SONA Global around affordable device innovation. On the left-hand side of the screen is Dr. Christina Dejean at one of our in-person conferences in Haiti. That was the last one that we held before the gang violence really erupted there. And she was teaching us how to use an aquarium pump as a negative pressure wound therapy pump for patients with complex injuries. And then when colleagues in Cameroon had the same clinical need, we connected Christina with our colleague Henry Ndasi in Cameroon, and he used the same system to provide care for these patients. And then over time, we've iterated and developed a really effective solution that, in 2022 and since then has really grown to help many, many patients around the world. And that was just a seed of an idea that through effective, rigorous research and implementation has really made a difference for a lot of patients. And so in our institution, in our organization, SONA, we have two devices that we've developed for external fixation and for wound management. And they go through this sort of process of tinkering, designing, innovating, rigorously testing in our laboratory to make sure that they're of the highest standard, training surgeons in essential principles of management using these devices, and then trialing them in a rigorous way to make sure that they're safely implemented into clinical care. And this is an example of that Vitara pump that was trialed in Cameroon. It went through a rigorous clinical trial there, and this is just one case of a hand that was managed that way. Um, Take home points. This is my last slide, really. Um, Building on a bilateral, on a foundation of bilateral partnership is the key to building towards this goal of musculoskeletal health equity. And we can do it in many different ways. And each one of you will have your passion, and I really encourage you to follow that passion, whether it's in research, education, advocacy, or resource development and innovation. Many, many different ways to tackle this huge problem, but I guarantee you, you will be more effective if you do it together through partnership. That partnership needs to include all of us, those in high-income countries, with low-income countries, with middle-income countries. Each of us is part of that broader solution, and we all have so much to contribute and learn. So I encourage all of you, as you explore this field of global hand therapy, global hand surgery, to first listen and read, and then second, teach and learn. So thank you so much. It's really such a pleasure to have been here today and to present. And I would welcome any comments. Thank you so much.
Kiran, we can't hear the applause, but we can certainly see it. So I think your presentation has really struck a note, and from the emotion that I'm sitting with, I am inspired and encouraged to do more and continue in pursuing. Although we might not achieve equity in our lifetime or our children's, it's no reason to not pursue it and get a lot further than where we are now. So thank you so much for that. There aren't questions in the chat, but it was great to see Andrew Matawa's comment. He says, I'm an occupational therapist working at Kacheria Rehabilitation Centre in Blantyre, and this presentation is a true reflection of how the situation is like here in Malawi. So Andrew, a few weeks ago, we were looking for hand therapists in Malawi to help us with the case. So it's wonderful to be able to connect in this space. I perhaps from my side, if there's nobody else who would like to ask a burning question, Kiran, have you had experience in initiating prevention interventions or prevention programs around the priorities that you mentioned?
As a surgeon, my focus has primarily been on treatment, to be honest. But many of my colleagues have worked on prevention, particularly my colleagues in Malawi. So Linda Tishkoto, who I mentioned previously, and another fantastic partner that we had there, Foster Mbowa, have developed prevention methodology and studies in Malawi, which has been really wonderful to see. I mean, the big challenge is road traffic injuries. And so Foster in particular was focusing on just teaching kids to avoid, crossing the road before looking both ways, telling drivers to be careful around schools, to be mindful of crosswalks, because it's a lot of children being hit by cars, which is obviously devastating to see. And then I have another fantastic partner in Ethiopia, who his name is Mengistu Mengesha. He has developed a phenomenal program called BOSAD. It's Bone Setter Associated Disability. It's all about preventing disability caused by treatment by bone setters, which is unfortunately a symptom of limited access to care, especially in rural areas, but also cultural beliefs and social beliefs that lead people to go see bone setters, which are very common in limited resource settings. Mengistu and his team in Hawassa, Ethiopia, and really across Ethiopia have done a remarkable job of studying the problem and trying to address it, prevent the problem at its source by teaching parents and teachers, by teaching bone setters, and by teaching local providers. So I think there's so much that we can do with prevention, but it needs to be really grassroots led, right? And I've been just very inspired by our colleagues who have taken that on.
Fantastic. And I think my question came from a place where I don't necessarily have the expertise, but the need for prevention is so overwhelming. So I think your point of really connecting with those who have expertise in community-run programs is essential. A couple more comments in the chat. If there are any OTs in hand therapy or any programs for OTs in hand therapy to volunteer or help out or to give advice or fundraise around low income settings. And I think perhaps a great place to start would be by joining the Global Occupational Therapy and Physiotherapy group, where we interact around that need. Kiran, I don't know if you want to speak to any other possible opportunities where people can connect.
Absolutely. I mean, I have this slide up here if you guys want to check out our websites, and certainly you can send me an email. I would be very happy to hear from anybody. When I end the presentation, Kirsty, I can put the link to that WhatsApp group in the chat so that folks can join if they're interested. There's so many ways to have a meaningful impact. And Kirsty, certainly for the therapists on the line, you probably have many resources for them. I know that you've been so wonderful in the webinars that we've organized with you. From our perspective, we do have a kind of service and education program that we run in the northern region of Malawi. There is another program run by the British Hand Society in the central region of Malawi. There are many programs out there. And the one point I'll make is, of course, you're welcome to apply and to be part of our network, but be part of a network. Be part of an organization that is doing meaningful work and has deep connections with those surgeons and therapists who are on the ground. You know, when the earthquake of 2010 hit Haiti, there were so many people who just showed up with good intentions, but bad results. And it's because they came without any infrastructure around them to support the kind of work that they were doing. And that can be devastating for the local providers and for the patients, despite the best of intentions. So I would encourage all of you to be part of the solution by being part of a good organization. Find a good organization and find people who can point you in the right direction so that the wonderful intentions that you have and the passion that you have can be delivered in a way that's like really, really meaningful.
Thank you. And yeah, that's sustainable. Kiran, thank you so much for your time. We're aware that you do need to leave to attend to other commitments, but thank you so much. And we'd be grateful if you can post. I think I managed to post the link to the physio and OT group, but if you could post that again, as well as the hand surgery group, that would be amazing. Thank you for joining us, and thank you for the incredible work that you do.
Thank you so much. Such a pleasure to be here today. Thank you for the invitation.
So Kiran took us, gave us an idea of the global unmet need for hand injury care, and established pillars to work towards striving for equity in musculoskeletal care and hand injury care. We're gonna zoom in a little bit from that broad perspective, and we're very grateful to have Terri-Ann Abrahams with us this evening. She is a South African occupational therapist, but joining us from the Republic of Ireland this evening. She graduated from the University of Cape Town in 2011 and has undertaken a number of postgraduate qualifications, including a postgraduate diploma in healthcare management, which I think we will get a sense of in her presentation. Over a period of 10 years, Terri-Ann established and developed the occupational therapy service at Khayelitsha Hospital. This is in one of South Africa's largest and fastest growing townships. This was against severe resource limitations, and in this under-resourced urban setting, Terri-Ann worked as a generalist OT and knows very well the challenges of tackling hands as a non-specialist while delivering all sorts of other rehabilitation and intervention. She's passionate about patient-centered care and about increasing access to essential health services. So Terri-Ann, we are looking forward to you sharing with us the lessons that you learned about establishing a therapy service in an under-resourced setting. You can go ahead and share your screen.
Okay. Hi, everybody. Thank you so much for the introduction, Kirsty. It's really nice to be with you all today. So I started working at Khayelitsha in 2014 as a really young therapist who had only been working for around 2.5 years prior to joining the KDH team. Why in the world I thought I was qualified enough to start an OT department? I'm not entirely sure. But a large contributing factor was that KDH didn't have ortho services. And as a young therapist, my only exposure had been to hand injuries in simulated sessions during my undergrad training. Aside from the lack of ortho experience, I felt really confident in my ability to figure out the rest. I just started a therapy service at a pediatric intermediate care facility, and whilst that was on a much smaller scale, I didn't even realize that's what I'd signed up to do initially. So working at Khayelitsha really felt like it would be both a significant challenge and an incredible opportunity. I'd initially planned to stay for 3 years and ended up staying for 10. KDH, for all intents and purposes, became a new home of sorts for me. It's where I had the great privilege of serving a community that was still struggling with the aftermath of the apartheid regime, where I worked alongside some incredible therapists, and importantly, where I matured as a therapist myself. I'm hoping that through sharing some of the reflections of my time starting a department, you'll be able to take some ideas away to trial or implement in your own places of work on a continued journey to improve services and access to care. So Khayelitsha in isiXhosa means new home. It's the largest township in Cape Town, as Kirsty mentioned, and it's the second largest in South Africa. It's about 30 to 35 kilometers from the city center and situated along the N2. For anyone who's visiting Cape Town, at some point when you're driving from the airport, you will see it on the left-hand side. It was established in 1980 by the apartheid government as an area in which Black Africans could be resettled as part of the Group Areas Act, amongst other apartheid-era legislation. And while the population size remains unclear, it's important to note that there was a 42% increase in the population between 2000 and 2015. It's also important to realize that the original planned population for the size of the area was 200,000, which if we look at the numbers provided by Census 2011, it's long since been exceeded. It's almost 50 years since Khayelitsha was created by the apartheid government, and here are some quick stats about the community. Around 75% of residents live in shacks in informal settlements. 1 in 3 people walk 200 meters or more to access clean water. Around 89% of households experience moderate to severe food insecurity. Around 70% of children aren't receiving any early childhood development interventions. Around 73% of adults haven't completed formal schooling. And the most common forms of employment are domestic work, service work, skilled and unskilled manual labor, and security services. KDH itself is a really nice looking hospital. I actually specifically drove to see it before I applied because I wanted to make sure that it was a hospital and not a clinic. I wanted to also know that if I looked outside while I was working there, if I got the job, that I'd be able to see the sky for my own sanity. KDH officially opened in February 2012 as a 230-bed family physician-led facility providing primary level services. No ortho. But to meet the needs of the community, it needed to evolve into a specialist-led facility, and this started happening from around 2016. This is an overview of established services at KDH when I joined the team in 2014. OT was never part of the plan. By the time I left at the end of June 2024, KDH had 340 official beds, but often operated above capacity. The major differences between when I started and when I left was the introduction of 3 new service areas, where then by then transitioned from being a primary level family physician-led facility to a specialist or consultant-led facility offering both primary and secondary level care, meaning that patients who required more complex or specialist care could now be managed at KDH instead of being transferred out. However, despite this transition, and even with the additional beds, the needs of the community still wasn't being met for various reasons. In the next 5 slides, I've created the most condensed version I could to give an overview of the OT department's growth over the years. So as mentioned, I joined in 2014 in June, and I was the first OT that was employed with very broad instructions to start the department. At the time that I joined, there was no formalized job description, there was no designated clinical or admin space, there was no budget, and I had no equipment. While my direct supervisor, who was the regional clinical manager and a trauma doctor by profession, is one of the nicest managers I've ever had, he had no insight into OT or what I should have been doing. With that said, he did give me 3 months without any clinical expectations to figure out immediate mid-term, and long-term plans for the OT service, which included identifying equipment and staffing that would be required, as well as all tentative budget requirements. I remember presenting this to the EXCO team and having some of the senior management laugh at me when I said that they would need to create appropriate spaces for OT to provide services in. In addition to meeting with the allied health members and clinical leads at KDH, I spent a good chunk of my time meeting with OTs within my referral pathway. That would be from clinic level all the way up to the tertiary hospital that we referred to and got referrals from, as well as relevant NGO and NPO members within the community. I was given my first space within about a month or so, and just because someone had resigned, and when we were doing a walkthrough, the space was unlocked and no one was in it. It was supposed to be for someone else, but they weren't at work that day. So, you know, a win's a win. I just needed somewhere to sit. A lot of people were unhappy, but it was a place for us to start from. In the next slide, these are some of the photos that we took between 2014 and 2017. So this is the office that I was given. So the first space we used became a combination admin/storage space. Quite literally made use of any and all open space available in this room while getting some of the basic equipment that we needed and building up stock of assistive devices we identified patients needed. The locum, who started in June 2015 as a one-year present to myself, we shared a desk. We used to take turns using the desktop or our own personal laptop, depending on who needed access to internet at the time. The middle picture is of the locum seeing the first hands outpatient that we saw in the middle of a passage in the outpatient department. It was with the patient's permission. And looking back, it was a tad dramatic, but it gained the attention that we needed without causing harm to patients, and we were eventually given access to a more appropriate space to try and match the forced service expansion. We were never informed that orthopedics would be joining the hospital or that services were being started. We just suddenly received an influx of referrals. Between 2018 and 2020, there was a rapid upscaling of services required. And while it wasn't the best option, the OT department was grown using locums to try and keep up with demands. Toward the end of 2018, my manager at the time identified a passage which was going past the rest of the allied health team as a potential space that could be converted for OT to use clinically and for some storage. The passage and waiting area reconstruction starting in 2019, with areas in the physio gym being converted into shared clinical spaces for OT and SLT to then access for clinical services. We were allocated containers on the ground of the hospital for storage, and we used these for wheelchairs and various assistive devices. I actually went back to look at the slide deck I put together for the very first presentation I did to the EXCO team after we moved into the space once it was completed. And sure, it wasn't the space I had initially mapped out in my presentation for a comprehensive OT service, but they did end up building a more appropriate space for us. And I really thought that, you know, younger me would have been really chuffed for advocating for OT and not allowing very senior people to just bulldoze me in that meeting. 2020 was a challenging, chaotic year for most people working within the health system at the time, but one of the highlights of 2020 for me was that our locums or funding was then made available for contract posts in lieu of needing to use agency funding for locums. So this is eventually what the entrance to the OT department looked like post the passage conversion. We got our first community service post in 2021. I'd started motivating for one in 2015. And then I went ahead and demotivated to deactivate that community service post and the previous contract post so that that money could be combined so that we could finance a second permanent post for the department, because at that stage, I desperately wanted there to be a second permanent post before we tried to expand with other types of staffing for a while. So the second permanent post was then approved around May 2020 with finances secured. The interview process started in June, and we were able to fill the post by October 2022. And then I started motivating again for a community service post to be added to the service from 2023 onwards. We didn't get a ComServe in 2023, but we did get one from 2024. And at this point, I truly felt like I'd accomplished the initial goals I'd set for myself when starting. It just goes back to what Kiran mentioned about space, staff, systems. It was clinical storage and admin space, appropriate equipment that we needed to provide services, a budget which was sufficient enough to buy in wheelchairs and assistive devices or aids that the patients required, and then a second permanent OT post and a community service post. What I've included is a very small snippet of the highlight reel for what was supposed to be a 3-year journey. But most of my time at Khayelitsha felt a lot like the third depiction of getting from point A to B. It was chaotic, blurry, and really incredibly exhausting. It was like having 1,000 tabs open all at once with never-ending to-do lists. I developed incredibly unhealthy, unsustainable habits during my time at Kaya. I had very few boundaries. I often worked 10 or more hours on site and took work home to do in the evenings and over weekends, and often still didn't feel like it was enough. I struggled to say no to more work or responsibility in other areas, despite the cost to me and often my team. And a large part of my identity became entangled with this one aspect of my life. It took almost 6 years before I actively started putting boundaries in place. So I 100 out of 10 recommend practicing occupational balance in your own life. For many of us working in under-resourced areas, we are often one of the biggest, if not the biggest, therapeutic tool we have access to. So first and foremost, look after yourself so you can continue serving your patients to the best of your ability. The following principles and practices aren't in any particular order, but you need to find mentors. It doesn't necessarily have to be someone that is more senior than you, but that definitely does come with its own set of benefits. When we first needed to start managing ortho patients, the locum OT who had joined the team ended up mentoring me. She'd previously been my student, but at the time that she joined KDH, she had a lot more practical experience managing hand injuries than I did. So she sat in on some of my sessions and I talk her through overviews of my plans based on patient diagnosis, and we went from there. To this day, my very first OT manager remains a mentor and has become a really close friend. And as I've gained experience in other areas, she's reached out to me to be mentored back. So it's become like a mutually beneficial relationship. You need to know which areas you're struggling in and then find people who have experience in those areas who are willing and able to guide and mentor you. You need to take time to get to know your colleagues, not only within rehab services, but nurses, consultants, the permanent doctors, both in and outside of the referral pathway you're working in. At your own facility, get to know the support staff, switchboard, supply chain, HR, information management. We work in complex systems, but people make up those systems, and treating people with respect and taking a genuine interest in others can truly just go such a long way. For me, accountability and integrity go hand in hand. You're very likely going to make mistakes or miss a referral or not get to something that you said you would. But when you do make a mistake or miss a referral, you need to make sure that you make it right. No excuses, just fix it. And if it's appropriate, apologize. For the first year, I was completely alone. When I took leave or got sick, there wasn't any cover, but the referrals still came through. It wasn't my fault that there wasn't cover, but it also wasn't the patient's fault that there wasn't an OT on site. So when I'd get back, I would collect all the referrals and then find all the information about what happened with the patient while they were admitted, where they were discharged to, and then make sure that I referred that patient to the next appropriate level of care for an assessment and treatment based on that therapist's findings. It wasn't great, but it was the best that I could do with what was available for me resource-wise at the time. You've got to do the right thing, even when it's harder or longer option, and you've got to do it consistently. Find yourself a work bestie. It's really easy to get overwhelmed and burnt out in health systems that are overburdened, but I promise a work bestie helps. And I don't necessarily mean someone you'll complain to. I mean someone who's going to inspire you, someone who's going to challenge you to be better. And sure, you can complain a little bit, but you're also going to get the work done. For me, it was the psychologist. Initially, it was a friendship based on proximity. She was in the office next to the office that I was given when I first started working there. But it grew because she was a force to be reckoned with. The level of trauma in Khayelitsha is unimaginable to most people, but she just took everything in her stride. She stayed open to new possibilities. She constantly tried new things. She put systems in place that she'll never see the benefit of, but she did it anyway. She was not only inspiring, but she became my on-site little cheerleader and a safe space when things were just too much and a moment was needed. We truly fed off of each other, and I only felt the full effect of being burnt out when she resigned and left KDH. So whether we like it or not, everything is political. I like to think about concepts in terms of systems and frameworks because my brain likes to create order in whatever chaotic situation we're finding ourselves in. So at a hospital or facility departmental level, you're going to be thinking about SOPs, possibly diagnosis-specific guidelines, remembering that the guidelines and we still need to clinically reason. And importantly, you need to know about your hospital or facility's operational plan or strategic plan for the year, because our planning should be in line with the overall direction that the facility we're working at is going in. Provincially, in the Western Cape, there's Healthcare 2030, but other provinces and countries will or should have their own strategic roadmaps. And then nationally or internationally, think about like the Mental Health Care Act, Children's Act, anything that's been gazetted and that's relevant to the patient population you're working with, white papers, World Health Organization documents, if your country's compliant member states. Consider national and provincial budget breakdowns. While most of us would like to make sure we're able to see our patients to the best of our abilities, the politics of health can't be escaped. To be in a position where you can appropriately advocate for patients and services, it's important to be aware of the policies that directly and indirectly impact your ability to provide those services. By no means am I aware of all the details in like the nitty-gritty stuff, but I made sure to have relevant policies saved. Initially, I had it in a file, in a hard copy, and eventually just on my desktop. And when I needed to, I could just revert back to those documents. To help me make my case, to use the correct terminology when I was speaking with senior management, because language also matters. And if we're speaking in a language that senior management knows and understands, it can show them that we're working towards the same end goal, and it's then a lot easier for them to consider what you're asking for. This is a very crude overview of the flow of a patient who is referred for inpatient OT and what they would follow. And then on the left, I found this infographic which just shows a patient's journey through the emergency department. And then on the right is a referral pathway of the Metro Health System within the Western Cape for OT services that I mind mapped quite early on during my time at Kaya. And I used as both a curtain in the office that had a giant window that was see-through, and also as a reference for orientating new staff members to the system that they would be working in. Health systems are so complex, and there's often so many moving parts, and it's often overwhelming for staff to get to grips with. So imagine what it's like for a patient who's trying to navigate that system. Make an effort to understand the system that you're working in and how different patient populations you see would need to navigate it. If systems don't exist, start creating them. They don't need to be perfect to start, but as you go along, keep what works well, change what doesn't, because nothing's really set in stone. What is the point of keeping stats? So, I mean, really just sit and think about what it is that you track or are asked to track, and then what it is that you do with that information. At KDH, the sum total of information required from me monthly was how many new wheelchair assessments were done and how many were issued. And then a head count that would be pulled off a billing system, which wasn't accurate as a statistics tool because that's not what it was for. Therapists were working their butts off, and that's the only information the department wanted reports on. So while I did track and provide that information, I also included a short narrative to accompany it when I submitted it via information management offices. And then more importantly, I started tracking things that mattered to me and to the OT team, and our ability to tell a story about the work that was actually being done in our department. So yes, I kept basic headcount information, but amongst other things, I also tracked service areas that were referring to us, waiting periods for in and out patients, functional outcomes on assessment and discharge for all patients, the Landrum outcome level on assessment and discharge, and whether the change in that outcome level was anticipated or not. Just before we started this, we got some of the questions that some of you had sent through, and two questions stood out to me that I thought you could use some data to potentially help you address. And it was how to improve compliance in rural settings, and then can the frequency of inpatient hand rehab be reduced to limit patient expense without compromising outcomes? Can't answer them specifically, but I wanted to give an example of how I used some data that we'd collected to help me make and justify delivery, like service delivery choices in the team. So when we first started seeing hand patients post-tendon nerve repairs for outpatient therapy, it was just me and one locum, and we were booking around 8 hands patients a day, and then also needing to get all the inpatients and admin and everything else. So initially, our the first attendance rates were high. We theoretically were doing everything we should have been in that session, assessing, educating, making a splint, showing how to do the home program, giving follow-up appointment information, but our follow-up rate was terrible. And then after reviewing attendance rate, I realized that we were also contributing significantly to our problems. Aside from the socioeconomic status, and as you know from earlier, most of the patients we were working with didn't have or wouldn't have had completed their formal education. We weren't explaining information in a way that made sense to patients or allowing time for them to truly process what was being said and then ask questions or clarify information that mattered to them. So we were rushing. It wasn't intentional, but we all know how it goes. When you're busy with a session, in the back of your mind, you've got 15 other things that still need to be done, and there's patients that's waiting, and there's ward patients that's waiting, and there's discharges. The list truly just goes on. It just wasn't working for us. So I looked at the data and I used that to make the service changes. If it was doing outpatients, wouldn't cover medical wards. That split worked for other departments in the hospital, but it didn't work for us. Medicine was our highest referral source, and also the area that we had the least impact in over a lifetime, because the patients we were seeing there had chronic diseases of lifestyle and often would be readmitted within a year or would pass away due to the severity of the illness. So we switched it up. Whoever covered ortho would then also be providing cover to the surgical wards where there were less inpatient referrals, but we could have a bigger impact over a patient's lifetime. So it was an area I really wanted my team to be able to spend time ensuring patients were successfully reintegrated into their homes and communities. I decreased the number of patients we booked into OPD slots and then increased the time that we allocated for direct contact time with the option to push it further if you needed to. We didn't take any walk-in patients. Were my managers happy? No. Did they eventually get on board? Yes. And over time, results started speaking for themselves. So to start off with, we weren't staffed properly, and I was doing the best I could with what was available to equitably ensure that patients had access to treatment that they needed at the time that they needed it. Surgery ward patients, which we previously were missing because of the medical wards being so busy, were now being seen promptly. They were receiving inpatient therapy and timelessly being referred to the next appropriate level of care. We were more visible in the wards, which gained us a lot of brownie points with the surgeons. Patients were now able to safely go home if they could go home, and the patients who needed extended admissions while awaiting rehab beds were no longer being surprise discharged because A, we were in the wards, and also we now had room to negotiate with the surgeons, which was a win as far as we were concerned because they didn't really want to keep patients that they weren't going to be operating on. For ortho patients, our follow-up rate improved significantly. Our outcomes also continued to improve because our follow-up rate improved. We were mostly able to get patients back to work within a 12-week period where that was indicated or with some accommodation. So they were either then fully discharged from our service or they would be referred on to the local clinic for continued rehab if that was what was indicated. We improved our working relationships with orthopedics. Interns now had to refer to us day zero post-op with a photo of the operation notes. Appointment dates were provided immediately, and then that would be included in discharge summaries, and we would try as far as possible to coordinate that initial OT appointment with the ortho follow-up so that there wasn't firstly, it would be less expensive for the patient because they had to come see the doctors anyway, and we could get them straight out of POP into an appropriate splint and start the exercises at maximum 2 weeks from when the operation was, but preferably before that if that was what was indicated. We were also able to advocate for patients better who needed surgical relooks because we had better relationships with the patients, we had better relationships with the ortho doctors. If their hand were not progressing the way that it should have been progressing, with them attending appointments, with them being compliant with their rehab, we could literally just walk them over to the orthos and then discuss with the consultant whether further surgery would be appropriate. Medicine services took a massive hit, and they complained quite loudly about it because it did negatively impact their service. But that essentially helped us get funding for a second OT locum, which was initially only for a period of 3 months. And then my manager realized that we just didn't have enough staff to do what needed to be done and extended that locum indefinitely. So keep and report on data that you're actually able to use to tell the story of the work that you're doing, because you've got to show how you're adding value. So these were really the principles or practices that stood out for me when I reflected on my time starting the OT department at KDH. But I just want to reiterate that it's also so important that you leave work at work, and that you find something that you're able to do at the end of your day to let your brain and body know that, that part of your day is done. And I think the only reason I managed 10 years, and a few of them being very, very burnt out, was to know why I wanted to be there in the first place. As chaotic and exhausting as my time at KDH really was, I mostly completely loved it. It was such a privilege getting to work with the community of Khayelitsha. My parents and most of my family still access government services, so it was really important to me to create and provide the type of services that I want my family to have access to. And I was often told that my expectations were way too high and that it would just be easier for everyone if I lowered them. I don't necessarily believe that that's true. I think that you can raise the bar and you can start with yourself. So thank you so much for your time. I'm not sure if there are any questions.
Terri-Ann, thank you so very much for an incredible presentation, and I hope you can see and feel that round of applause. Perhaps I can just quote some of the quotes. I'm so inspired as a ComServe, another person loving your story, especially coming from a severely under-resourced institution. Another one, you're so inspiring. And then, Johanna, I can relate to your story, and listening to you, it actually has given me hope and strength to continue to advocate for patients to get efficient OT treatment in my hospital. So thank you for your honesty and vulnerability, and for doing an excellent job in the 10 years you served the community of Khayelitsha. We have one question that I'd like to pose to you. Firstly, Amanda would like to say she'd like to commend your advocacy and leadership demonstrated in your context. Her question pertains to the management of hand injuries in patients from low-income backgrounds like Khayelitsha, who rely heavily on manual labor, such as domestic work, as you mentioned, for their livelihoods. In such cases, how do you balance the need for safe immobilization to promote healing, which may limit hand function, with the need to enable patients to return to work, which may put them at risk of further complications, especially when their priority is return to work because of the economic factors? And I know we've chatted about this before, and I would love to get your insights on that question.
Amanda, often if the patient was working on that very initial assessment, I would fill out an application for the disability grant, like off the bat. I would just immediately in that first session, because that's a massive, if you're not working, and essentially all the patients that we were seeing, if they didn't work, they didn't get paid. So if you weren't working and you showed up to your first appointment, whether the doctor had recommended it or not, I was just going to fill out a referral for you to go to SASSA and go and sort out the disability grant, so that one aspect of your stress could be taken away, and we could try and then focus on actually doing the therapy part of it. The second thing I would do is, as we were going along, once we were able to start getting them using their hand functionally, it really just depended on what work they were actually doing, and then the relationship that they had with their manager or their boss, and so I would often encourage our patients to go to their place of work and go and speak to their boss themselves. I would never write the letter on my own. I would have them go and speak to their boss and explain, that they've had this injury, but that they are coming for rehabilitation, and we've spoken about their work. And if when we spoke about their work, there were things that we identified that they could do safely, I would give them that list and say, you can tell them I could come, and maybe I don't get paid the full amount, but I could come and I could do these things safely while I continue getting hand rehab. And then I'd always tell them, after you've had that conversation, when you see me again, if your boss has questions and they want something from your therapist, let's phone them together at your next appointment so that you hear what's being asked, and I can explain things with you next to me as honestly as possible to your boss, and then we can try and figure out the timeline. We reverted to that because initially we were writing letters and the ortho surgeons were writing letters about light duty. But what does light duty mean? What does light duty mean when that's not an option for someone who's doing manual labor? And then often our patients would come back and say, they said they don't need my help anymore, so now I don't have a job. So that was kind of the way that we approached it from that side. And then as soon as they were able to go back to work, we would get them back to work. But it was often quite tight. Not every employer was as understanding as the next. So it really just did depend employer to employer. Yeah, and sometimes we'd have to push things a little bit further. If we needed to do that, I would often consult with colleagues at Tygerberg or colleagues at Grooteskied if I just wasn't sure, because I was seeing hands in between lots of other things, and I often felt out of my comfort zone because I didn't want to make recommendations that could potentially ruin someone's hand for the rest of their lives. And then in combination with them, I would go and get approval from the ortho doctors, like go and speak to them, tell them what the situation is. We'd speak a little bit about the work, and we'd talk a little bit about the load and what that would be like on the hand, and then see, what would be feasible in terms of getting them back sooner rather than later. I hope that answers the question.
Terri-Ann, thank you so very much for such rich insights, and really for giving your heart and soul to the profession. We are grateful for you. There are a couple more questions in the chat that I would be grateful if you could answer while we move on to our next presentation. We're moving from looking at a service and developing a service as a whole to looking at advocating to improve outcomes for specific conditions or addressing particular needs in your occupational therapy or physiotherapy service. And for that, I'd like to introduce Nicola Ehlers. Nicola is joining us from Johannesburg, South Africa. She graduated with an occupational therapy degree from the University of the Witwatersrand, and then completed her postgraduate diploma in hand therapy in Pretoria. She's worked for around 15 years in a low resource setting, delivering hand injury care, for which she has a great passion. And appreciating the challenges of hand therapy in this session, and along with a passion for open access education, Nicola has driven the development of this Open Hand Therapy initiative and continues to lead and manage the initiative's operations with her very diverse skill set, and she does this incredibly efficiently. Nicola has presented a number of guest therapy lectures and a number of papers at conferences, and it is an honor to have Nicola share with us this evening on advocating to improve your patient outcomes. Nicola, over to you.
Thank you. Okay. So I was working at Laratong Hospital. So Laratong Hospital is an 800-bed regional public hospital on the outskirts of Johannesburg. So that may sound big, but the truth is that it's not quite big enough for the rapidly growing population that it is expected to serve. As most of you will know from working in similar settings, resources are limited, surgery is mostly unavailable, staff are stretched thin, and the patients themselves can be quite interesting characters. So this is where Agnes decided to come when she fell and broke her finger. So the injury happened in the rural area where she was staying, but she believed that the services there were not up to standard. So she came to stay with family nearby so she could get better help. The help that she got looked like this, not anywhere near the recommended treatment for a proximal phalanx fracture. After struggling without any use of her dominant right hand for the very long period of 7 weeks, her cast was finally removed and she was sent to me for hand therapy. By this time, her hand was extremely stiff, with very little hope of any improvements. She would likely spend the rest of her life struggling with simple tasks like cooking and doing laundry. She was a cleaner, but considering her age and level of disability, it was unlikely that she would ever return to work. Agnes is just one of many examples of how incorrect or inadequate treatment can lead to poor results. If her injury could just have been managed correctly, her story could have gone very differently. So when was the last time you saw a patient with a stiff hand or adhered tendons? Could their results have been different if their management had just been more evidence-based? Maybe if they were referred for hand therapy sooner, or if they were immobilized differently, or maybe for a shorter period. And is there a pattern? Maybe there's a particular doctor who always refers late, or like in my case, a certain condition that is always managed correctly. And do you want to do something about it? So even though Agnes's poor result wasn't my fault, I still felt responsible for it. I decided that I was going to change the way the proximal phalanx fractures were managed at my hospital, so that patients like Agnes could get good results and could go back to their work and daily lives without any difficulties. And maybe you think that as an OT or physio, you don't have the influence to advocate for doctors, nurses, or other therapists to change their practice in a way that you know will benefit your patients. But I want to prove to you today that that is not the case at all. I'm going to show you that change is possible, and I'm going to do that by taking you through the process that I followed and showing you how you can apply it to your own problem. First, you have to decide what problem. You may already know what you need to address. But if you are working in a low-resource setting, you might find that pretty much every condition is not ideally managed and ends up with a stiff hand, leaving you with a very long list of problems. And I know what that's like. I know it feels very overwhelming because there is so much that you need to change that you don't even know where to start. So if this is you, then my recommendation is to start with a smaller problem first, like maybe education or increasing awareness. And as you achieve success with smaller problems, bigger problems become easier to address. And then before you know it, you'll be ready to tackle problems that don't really seem so possible right now. So, what is going badly that you want to change? Choose a problem and think about that problem as we continue. And rather than making notes on how I address my problem, make notes on how you plan to address yours. First, let's do some research on your problem. So how much do you know about it? You know something is wrong, but do you know what should be happening instead? I mean, it seems obvious that putting Agnes's hand in a cast like this for 7 weeks is going to lead to joint stiffness. But what could evidence-based practice have looked like in this case? Can you show how much this problem is impacting your patients? So this is essential to prove to everyone that your problem is something that deserves their attention. And why is it like this in the first place? If you don't understand how the problem developed, then it's going to be a lot harder to know what you are aiming at when you are trying to fix it. Okay, so there are lots of options available these days to help you find out what should be happening. That just takes a bit of research. To describe what is actually happening more clearly, and to get some specific stats or examples on how it is affecting your patients, you can review some past patient records. You can also start now by making some notes on how the patients that you see are managed and what their outcomes are. Or another option would be to talk to other people involved in the problem so that you can get more insights. To know why it is like this, it can help to consider the barriers to implementing evidence-based practice in your setting. And to do this, it's important to actually talk to the people involved, because you need to find out why they are doing what they are doing. Okay, so to find out what should happen, I had a look at some journal articles. So I focused on extra-articular fractures, which were managed conservatively. I found these 3 studies, which used these 3 methods. So they all included splinting or casting for 3 to 4 weeks, with the MP joint inflection, and then active exercises of the IP joints were started immediately. So for this study specifically, I have some pictures of their results. And they look really good. I mean, if I had a proximal phalanx fracture, I would be super happy with a result like this. The standard outcome measure in most of the studies was total active motion. So to calculate total active motion, what you do is you measure and add together the degrees of flexion at each joint, and then you subtract any extension lags. So in this study, the average total active motion was 253 degrees, which is really good, and this was measured at an average of 6 weeks for the injury. So I knew this was not anywhere near what we were doing, and I also knew that our results were nothing like this. But I wanted some proof. So I had a look at a few of my patient records. I found that these fractures were typically immobilized for 4 to 7 weeks, which is really long. And they were immobilized with the MP joints in extension instead of flexion, and with no movement of the IP joints possible. So here are some examples of the results that we were getting. So this guy at 6 weeks, all his fingers were stiff. With this lady, I tried everything, but at 19 weeks, this is the best result that we could get. This guy worked really hard for quite some time, but he did finally get an almost perfect result. Of all the patients I looked at, this was the only good result. And then Agnes, you have already met. So there was an average total active motion of only 187 degrees, and that was measured at an average of 12 weeks. So as you can see, there was this huge gap between evidence and practice, and the outcomes showed that what we were doing was not working. But why was it like this? Why were the doctors not using evidence-based practice? So here are some of the barriers to healthcare professionals using current evidence that I found in the literature. So to understand which ones were applicable to my problem, I spoke to one of the doctors. So I wanted to be able to see things from his perspective. So I mentioned what I'd found looking at our patients, and I asked him why he thought it was like this. So I discovered that our biggest challenges were doctors not being aware of the evidence-based practice, and they were also set in their ways. And then another thing that I discovered was that they were also likely unaware that we were getting such bad results, and they were therefore unconvinced that changing their management would really make that big of a difference. So from this, I could already start to see more clearly what I needed to do to address this problem. Okay, so the next step is to look at possible solutions. So basically, we want to find out, how do you think these patients should be managed? So here, the most important thing to consider is context. It doesn't help to choose a management option that gets the best results in the literature or that worked in someone else's hospital. You have to develop a solution that is right for your context. And to achieve this, you may need to adapt or even combine different management options. Okay, so these are the three options that I found. So this one is the one that got the best results in the literature. But I have really struggled in the past to convince my patients to wear removable splints full time. So I wasn't super keen on this. This one uses plaster of Paris or POP, and that's what is used to manage all fractures in the South African public sector. So it is very readily available. But in my hospital, POP is applied by POP technicians. So if I chose this option, I would need to train those POP technicians. And that was complicated because the staff were always rotating. So not that one either. So instead, what I decided to do was to do casting with synthetic casting tape. I had this available in my department. It's non-removable, it's lightweight, and it looks like it'll be really easy for patients to exercise and to use their hand with light function with something like this one. Okay, so I decided that a good and realistic solution would be for the doctors to refer patients with proximal phalanx fractures to OT immediately. I would then make a cast and teach them exercises. They could then follow up as determined by the doctor for control x-rays, and then I would see them on the same day. After 4 weeks, the cast could be removed, and they would again attend OT, then they would continue with follow-up as needed. So I believe that this would work well in my setting, although I knew that my plan could change as I got input from others. But I'm sure you can see how you may have to develop a very different solution for your setting. Okay, so the next step is to figure out how you are going to achieve this. So basically, what process do you need to go through in order to implement your solution? The important thing here is to encourage collaboration. If you just tell people what to do, they're probably not going to do it. They need to feel involved, they need to take ownership of the solution. Okay, so here are some implementation options that I found in the literature. So the first one is training. So this could be a discussion with one doctor who always refers late. It could be a presentation to all the nurses on how to identify patients that need to be referred for therapy. If you're a therapist working in the clinic and you have concerns about the management of patients at your referring hospital, then you could bring it up in a meeting with the hospital-based therapists. Another option is an opinion leader. So for example, you want to address late referrals and you find that there are 1 or 2 doctors who are on your side, then you could speak to them about encouraging other doctors to refer early as well. Then there's patient education, with the theory that patients will then ask for the correct treatment themselves. So I chose training. And because I wanted to advocate for all the doctors to change their management, I decided to do a group presentation. The problem is that none of these options are very effective. So even training, according to the literature, if you can get people to change their performance by 10%, then you are doing pretty well. And that's really not much. So to understand why it's like this, we need to consider the process that we go through as healthcare professionals when we implement new techniques or guidelines. So first, we obviously need to be made aware of the guidelines. But knowing what we should do isn't enough, right? We need to also agree that it is necessary. And the best way to reach agreement is through interaction and discussion and collaboration. We need to have the opportunity to ask questions and to have our concerns addressed. Then we will hopefully start to adopt the guidelines, and eventually we will be carrying them out consistently. So as I said, I knew from speaking to one of the doctors that awareness was a problem. And I knew that going all the way from awareness to adoption in one presentation was probably unrealistic. I mean, how often have you heard about something completely new and started doing it immediately? But I wanted to do my best, so I used every technique I could think of. I described the problem using clear and direct language. I included patient stories, such as that of Agnes, because stories are really a powerful tool for making problems feel real. I made my presentation as interesting as possible, using pictures, videos, graphs, and flowcharts. I addressed possible barriers and explained the benefits of my solution. And then, most importantly, throughout the presentation, I encouraged discussion and collaboration. I asked the doctors why they chose the management they did. I asked them if they had heard of the evidence-based guidelines. I asked them what they thought about my proposed solution. I asked them if they thought it was realistic, and I invited them to express any concerns or suggest any changes. So did it work? Well, it seemed to go well. My colleague who came with me gave me some positive feedback, and the doctors seemed to be listening, so I definitely did create awareness. But had anyone adopted my solution? So the next step is to see if there are any changes. So to do this, you will need to find a way to monitor how well or how frequently your solution is being implemented. So after a few months, it was clear that only one doctor had adopted the solution I suggested. So he had said during the presentation that he knew about the evidence-based guidelines and he agreed with them. So for him, adopting them wasn't a very big step. He also decided that this method should be used for certain metacarpal fractures as well, so that was really cool. He referred a few patients to us, and as you can see, they did really, really well. So we had a good solution. It did need some adjustments, and my colleague and I had to make quite a few changes to perfect our technique, but overall, it was the implementation step that we needed to go back to. Okay, so this time I decided to take a slightly different approach. The other doctor in my first presentation who had said that he agreed with my solution was the head of department. So I figured he could be very effective as an opinion leader, and I went to him directly. So I asked him if I could get his opinion on some of the patients that I had seen since my first presentation. So I showed him, case by case, how the old way of doing things was leading to poor results, but how patients managed with the new way were doing really well. So he appeared to be completely convinced, and he even arranged a date for me to do this same presentation for all the other doctors. So now I had already made them aware of my solution, and now I had the opportunity to address the next barrier of them being unconvinced that a change was really needed, again while encouraging discussion and collaboration. So did it work this time? This time we had a lot more success. So more than half of the patients who came to the hospital with new proximal phalanx and metacarpal fractures were referred early to OT. They were immobilized for 3 to 4 weeks as recommended. And here are some examples of the results that we got. And as you can see, these patients did really, really well. The average total active motion was 208 degrees, and this was measured at an average of 4 weeks. What's interesting here is that for all but one patient, this was measured on the day that the cast was removed, because they either didn't need to come for further therapy because their hand was doing so well, or they defaulted the next appointment because they felt that they were fine. So it's likely that their final results were even better than this. But all this time, I still didn't stop thinking about Agnes. If she had broken her finger a year later, her outcome may have been very, very different. But even though I couldn't help her, there were so many patients who regained full hand function and returned to their daily lives without any restrictions because of what we did. But this is not about us. And it's also not about the effectiveness of a specific treatment. It's about finding a solution to a problem that is appropriate to your setting and implementing it, persevering through frustrations and failures. You are where you are for a reason. And wherever you are in a unique position to change your patients' lives. You can go back to work tomorrow and carry on like normal. Or you can refuse to accept things the way they are. You can challenge the status quo, and you can make an impact that lasts a lifetime. And you can start tomorrow. So I've put a list here of 3 things that you can already do tomorrow to start advocating for change. First, you can identify one condition where your patients get bad results, and you can do some research on how it should be managed. And the whole time, you're going to be picturing how that research could be adapted to fit into your context. And include your colleagues in this process as well, because they may have a perspective that you haven't considered. Second, and this links with what Terri-Ann was saying as well, it's important to improve your relationship with the people who are involved in the problem. So find opportunities to talk to them. Find out if there's a multidisciplinary meeting or a ward round that you can attend. It's going to be a lot easier to discuss your problems with them if they already know who you are and where you come from. And lastly, look differently at patients like Agnes. Their poor outcomes are not your fault, but you can do something about it. Picture a future where things are different. You don't need to know the steps to get there just yet. That will come with time. Thank you.
Nicola, thank you for an incredibly inspiring presentation. And I think just evidence of slowing down and tackling a problem systematically and patiently. And we really appreciate you sharing that that journey with us and for sharing all your expertise. We're so grateful. Now on to our last presentation. We looked at the unmet need, the big picture unmet need for hand injury care. Then we looked at starting a service that included hand injury care and then improving aspects within that service. And now we're going to look at a very important core of sustainably increasing access to quality rehabilitation and care, and that is looking after ourselves. So staying whole within a broken system. And it's my pleasure to introduce Erica Conybeare, also joining us from Johannesburg in South Africa. She is a lecturer at the University of the Witwatersrand. She's also one of the Open Hand Therapy Initiative team, where she, amongst many other things, does our social media. And Erica wouldn't describe herself as a hand therapist, although she delivered hand injury care in a deep rural hospital in South Africa for 3 years. So she knows the challenges of being a generalist and working in a low resource setting. But Erica has a master's in public health. She's an OT with a master's in public health. And so she's passionate about effecting system level change within health systems. But her other passion is trauma-informed therapy, and it's out of this place of expertise that she will be sharing with us this evening. Erica, thank you for your time, and we look forward to what you will share with us.
Thanks so much, Kirsty, for the generous introduction. Let me just share my PowerPoint. Okay, so yeah, thank you for all the previous presenters that I feel like have set the scene for us. I am wearing a few different hats for this evening. I feel like it's a combination of some of my different work. Kirsty mentioned my role in the occupational therapy department at Wits and in Open Hand, and my part-time other job is a practice called Trauma Help. I've completed my trauma and resilience life coaching qualification. Yeah, and also like Kirsty mentioned, I worked at a rural hospital for 3 years in Eastern Cape, and I've put a photo of this hospital on the first slide. It was, yeah, a real privilege to work there for the time that I did, and I'm so grateful for the lessons learned. This evening I'm going to share some of the lessons that I have learned looking back on some of my experiences, and some of you may resonate with them, some of you may not, depending on your setting, but hopefully you can learn some new things about trauma-informed care and how to look after yourself when things get tough. So just to share kind of the learning objectives of where I'm going, I would like you to gain a neurophysiological understanding of stress and trauma, and to be able to evaluate your own state of regulation using the window of tolerance. I'd like you to understand the concepts of vicarious trauma and compassion fatigue, and I'm going to introduce you to a very cool tool called the ProQual. And I'd love you to gain some practical principles on how to build personal and professional resilience. So firstly, just to share younger me, I was a young rural therapist. I'd graduated from UCT in 2017, and I was very excited to be placed at a rural hospital for my community service year. I was full of an optimistic hope. I was passionate about social justice. I was ready to change the world, and I was going to a new area all on my own with no support system, and I was actually a little unprepared for the magnitude of some of the things that I was about to face. I put this picture on the slide. It's a photo that one of the nursing staff took of me in my only session with this little boy. He sadly passed away from severe acute malnutrition when I came to the ward. By the time I came to the ward the next day for a follow-up session. And I share this because his death affected me quite deeply, and it wasn't necessarily because I had a particular bond with him after one session. It wasn't necessarily because it was the first time it had happened, or because there was anything unique about his situation. But I think it was on the back of seeing a lot of poverty, a lot of suffering, and the injustice of having a baby pass away from a completely preventable disease was just something that at that point in time, I just didn't have the capacity to process it. Yeah, so I'll kind of use that story as a bit of an anchor point and share some of my reflections as we go. So it's helpful to develop a little bit of an understanding of stress, right? Because our jobs are stressful. And some of you may be quite familiar with the Yerkes-Dodson curve. And this a bit of theory shows us that we do actually need a bit of stress, right? I needed a bit of stress to get this PowerPoint together in time. And if we didn't have stress, we maybe wouldn't be motivated to do too much. But stress does get to a point where we can move into a state of exhaustion or struggle with anxiety, and a prolonged ongoing stress leads to burnout. And why does this happen? So to give you a little bit of a neurophysiological understanding of what's happening in your body with stress, I'm going to walk you through what's happening in your brain and your nervous system and your autonomic nervous system. So when we perceive a threat, I often use the example of being a female walking down the road with my handbag, maybe in the center of Joburg, and if I see a dodgy looking guy at the other end of the street walking towards me, I usually have an increased heart rate, and it triggers a bit of a stress response, okay? And a perceived threat is informed by our painful past learning, right? So in this situation, my painful past learning is I've seen, stats on gender-based violence. I've heard news article stories. I'm aware that this could be a potentially dangerous situation. I don't know, it could be fine. But my brain perceives a threat, right? And that perceived threat leads to a fight, flight, or freeze response in our autonomic nervous system. At a neurological level, our survival brain, a part of our brain called the amygdala, sets off an alarm. Our thinking brain, which is our frontal cortex, goes offline because I don't really need to be able to think too clearly in a situation of survival. And I lose the ability to communicate well and to logically reason. And at a hormonal level, there's a big dump of stress hormones, right? There's adrenaline, noradrenaline, and cortisol. At a physiological level, I have an increased heart rate, my muscles tense up, I have increased energy, my breathing rate increases and my breathing volume decreases. Unfortunately, there's also a decrease in our happy hormones like dopamine, oxytocin, serotonin, and endorphins. So this is great, right? Because our brains and our bodies are wired for survival, and that's a good thing. If we are perceiving a threat chronically, intensely, often, it ends up being unhealthy for our system to have this constant dump of stress hormones. So to come back to my story, after several painful past learnings of having patients who I've seen pass away, even just walking into the room and scanning the ward to see an empty bed where one of my patients were would trigger a stress response. And that dump of stress hormones would come and move me into a fight or flight mode. Another really helpful piece of theory is the window of tolerance. It is also called the window of capacity, because I think there's been some critique in recent literature about the word tolerance. And it's basically the same thing, but I like to speak about the 3 zones. Your green zone is your regulated zone. This is where I'm the me I want to be, I'm calm, I'm happy, I'm relaxed, I'm at peace with the world. And ideally we want to be operating in a regulated state majority of the time, because when we're in this zone, you're able to use your prefrontal cortex really well, or otherwise called your thinking brain. When we move into fight or flight mode, we move into the red zone, right? This is what I mentioned about the amygdala setting off an alarm if we sense danger. Some people tend to respond a bit more quickly into a freeze zone. So sometimes people shut down, and this is mostly out of that survival area of the brain and the lower brainstem, which is focused on self-preservation. When we operate in the freeze zone, we often feel that low energy, a bit depressed, a bit spacey. I often have that feeling of, oh, I just can't get out of bed in the morning, and that means that I'm in the freeze zone. So why the window of tolerance is quite helpful is because it helps us to identify which state of regulation our body is in. And when we can identify which state our body is in, then we can put strategies in place in order to move back into the green zone, into a regulated state. Everybody is a little bit different on how their nervous system responds. I tend to operate a lot more in a fight or flight mode, and particularly in the years that I was a young therapist in a low resource setting, I operated a lot out of a state of anxiety. I put a lot of my pressure on myself to learn things very quickly. I took the difficulties that I faced and patient stories really hard, and I often felt quite stressed about my work because of the pressure I put on myself. Some of the self-regulation things that I do to try and down-regulate, I enjoy running. Breathing is a really helpful way, deep breathing, diaphragmatic breathing, to calm your autonomic nervous system and come back into a regulated state. I tended to operate in the red zone quite a lot, and then I would crash and move down into the blue zone and struggled with the depression every now and then. And there's also a lot of techniques that you can do to move from the free zone back into a regulated state. A lot of things that involve movement help to get out of that free zone. I personally find having a cold shower or jumping in a swimming pool, if that's available, really helps bring me up from that low depressed space back into a regulated state. Everybody's different. The concept is up regulation and down regulation, and there's lots you can Google on the internet to learn a little bit more. So understanding the physiology behind this helps us make sense of a few other concepts that are really important to cover tonight. The first is the concept of vicarious or secondary trauma. The problem with being therapists and working in health caring professions is that we don't only work with our own trauma, we work with the trauma of other people. And so vicarious or secondary trauma can be defined as the emotional or psychological impact experienced by professionals who are repeatedly exposed to others' traumas through empathetic engagement. A lot of us decide to be therapists, I know I did, because we want to be involved in helping people, so we care, right? It involves the cumulative changes of cognitive schemas such as beliefs around safety, trust, and control. It can manifest as emotional exhaustion, intrusive imagery, and shifts in worldview. I personally struggled with a little bit of believing that the world was still good after seeing so much suffering and poverty and death. The other concept that's helpful to highlight is the concept of burnout, and it was quite cool to hear, well, not quite cool, but Terri-Ann did touch on it in her presentation and highlighted how when she put 110% into her work and worked long hours and didn't look after herself, she faced burnout many of the years that she was working hard in Kailicha. So burnout can be defined as a syndrome of emotional exhaustion, depersonalization, and a reduced personal accomplishment that can occur in individuals who do people work of some kind. The next concept I want to introduce you to is the concept of compassion fatigue. So Charles Figley, quite a long time ago, conceptualized compassion fatigue as a combination of both burnout and secondary trauma. It's a combination of psychological, physiological, which we've dived into quite a lot, is what's happening on a physiological level, moral and spiritual distress caused by prolonged exposure to the hardship in the environment. Sorry, I just need to move this window. Prolonged exposure to a toxic environment. It's important just to note that it's not a sign of weakness, a character flaw, or a moral failing or pathology, but it should be understood as a natural consequence of caring for others. I think often in these 3 years and for a long time afterwards, I often ask the question, is something wrong with me? Like, this is where I wanted to go. This is what I'm passionate about. Why do I struggle so much? And maybe some of you have asked those same questions. Am I just not strong enough? Have I not just developed, do I not have good enough coping skills? But it is really a reality of what many practitioners face in practice at some point in their careers. Some helpful resources just to be aware of. There's a really cool website called the ProQual, which looks at the professional quality of life. There's some really nice resources and definitions and tools that you can go and look up. I have provided you with a very helpful self-assessment as a handout for this presentation. And using these resources can help you monitor how you're doing in compassion fatigue and secondary trauma and compassion satisfaction. It's really helpful to just do a check-in on how am I on a regular basis. So the recommendation is to complete it every 6 months or every year to just see how you're doing. And if you're not doing so well, then to actually think about getting some help. So then for the second bit of the presentation, to actually ask the question, how do we combat some of this? The briefing that Kirsty gave me was, how do we build personal and professional resilience? So we throw the word resilience around quite a bit, but what do we actually mean when we say resilience? Maybe it's first helpful to say what it's not. Resilience is not bouncing back. Unfortunately, unlike rubber bands, we don't just bounce back to our original state. Human beings are not the same as a bouncy ball, and that illustration of resilience being bouncing back is not always the most helpful one to use. It's also not a destination. It's not that I've done a whole bunch of work and now I can claim to be resilient. It doesn't quite work that way. It's not returning to normal. I mean, what is normal anyway? Sometimes we kind of want to go back to the person we used to be, go back to how I felt before. But going back is not always an indication of growth. It should also not be presumed. I think there's a lot of comments that go out there, things like children are resilient, they'll be fine. A lot of our understanding of brain science these days is telling us that children are not as resilient as they previously thought to be. They're actually in very sensitive developmental states and should be protected as such. There's also a few comments that I sometimes hear is, the students these days are not as resilient as they used to be. And I kind of question the logic of that. Maybe we should unpack a little bit by what we mean by resilient. It's also not purely an individual trait, which is often how we speak about it. Resilience is less about personal grit, but it's more about collective capacity. It's so important to think about our relationships, the institutions that we operate in, and the social networks that hold us when we think about resilience. So what is it then? It's the ability to adapt. It's to look at a situation that is maybe not what you thought it might be, and maybe not something you're prepared for. I wasn't prepared for a lot of things that I saw in rural Eastern Cape, but it's the ability to pivot and change and to do things differently than you did before. It's just a growth. And this is a helpful one when we're thinking about returning back to normal. Looking back at the young, optimistic therapist I was when I graduated from UCT is not the same therapist I am today. Somebody once asked me, like, would your younger self be proud of where you are today? And I think my younger self would be a bit surprised by where I've landed. But if I look back on the years, there's been a lot of growth has led to where I am. So it's about gleaning wisdom. I'm so grateful for the years that I spent in rural Eastern Cape because I learned so much. And I think the ability to count the lessons and apply those lessons to other areas of life is so valuable. Sometimes we need to rewrite our story, and to redefine who we are and redefine what we thought it would look like and what it actually ended up being like. And that's okay that the story looks different. Often when we experience these difficult situations, we lose trust. We lose trust in other people who have disappointed us. We lose trust in institutions that should have served us. We lose trust in the goodness that we thought we would see in a place. And giving yourself permission to trust is sometimes a good indication of whether you've built some resilience or not. The other really important thing I learned is the importance of building a support network. So resilience really does arise from relationships, networks, families, communities, and workplaces. I speak about the hospital as being a really tough time, but actually the hospital was a really supportive space in terms of the clinical team. There was a lot of good in the way that they did healthcare. There was a lot of people who were passionate about serving that came together. And I really value that. And I know that might not be the same in your situation. Support systems strengthen our resilience through system level efforts. And the resilience of those around us can directly feed our own. And our resilience in turn then feeds back into a system. I really appreciated how Terri-Ann spoke about having a mentor, having a work bestie. Those are all excellent examples of building her support system in a difficult place. Connection is protective. A lot of literature in many different fields show us that people who have better social connections are happier and stronger and manage to work through hardship a lot easier. So just to pull out some key thoughts as we close up, I see we're at 9 o'clock almost, but the key strategies of developing resilience. So firstly, regulation strategies, thinking about the window of tolerance and how you can return to the green zone. There's lots of resources out there that can help you to build in regulation strategies into your day-to-day life. Monitor yourself, use the ProQual. It's really cool and really helpful, and sometimes just having something on paper to really check in on how you're doing, because we can be a bit delusional, can be super helpful. And if you're getting some hectic ProQual scores, think about asking for help. I ask for help often. Sometimes I actually ask for support. The problem of rural communities is that you have a rapid staff turnover rate, and sometimes the support system that I initially built was non-existent after a while because people left, so I had to intentionally build a new one. A robust support system is non-negotiable. I hope you picked that up. And also to think about work boundaries, and I'm glad Terri-Ann touched on this as well, and life-giving activities. I hope you've appreciated some of the pretty pictures I put on my slides. They were all beautiful parts of working in rural Eastern Cape, trips to the beach, runs in the mountains, were all things that helped give me life in the 3 years that I were there. And also just thinking a little bit about who I am. So I did a lot better in small groups and not so well in big groups when it came to socializing, and picking those activities and putting time and effort into that really made a big difference. So that's where I'm going to leave you at maybe 1 minute past 9. So there's some references. I've put the various email addresses from my different roles in different places on the slide, and yeah, I'll be very happy for you to reach out if you have any questions.
Erica, once again, I hope you can see and feel the great round of applause that you're getting. And I think Pulani's message in the chat is that this is very hopeful. Thank you very much. Is a very, very fitting way to end this evening's presentations. And as a therapist who experienced severe burnout early in my career, as a therapist that got psychological help a number of times, it's such a joy that we can be sharing these strategies with each other to build more resilient, a more resilient occupational therapy and physiotherapy profession. I want to say an incredibly big thank you to everybody who has attended tonight, and a great thank you to all of our presenters who have volunteered their time to present tonight. It takes many hours of preparation, not just the time set aside for this evening. So thank you very much for that. Just before we go, I just want to remind you that in order to get your continuous education unit for tonight, you need to have attended the whole webinar. And then you need to fill out the questionnaire, the evaluation questionnaire, within 24 hours. Then our next webinar, we're really excited that on the 3rd of March, we'll be looking at when you're stuck with stiffness, an introduction to casting motion to mobilize stiffness. So SIMS has been a request from participants in our previous webinars. And obviously stiffness is a very common secondary complication following hand injuries. And a colleague will be joining us from Bulgaria to present an introduction to SIMS. She's been part of a team that has developed a traveling SIMS course in the United States, and it will be a privilege to have her and learn from her. Then to keep up to date with our webinars, please follow us on social media, or you're welcome to scan this QR code and we will add you to our mailing list. But for now, thank you for joining us and have a good rest of the evening.